Hi, everyone. Welcome to our Case Med Minute question review series, in which we're going to use a question on the pituitary gland today to talk about a question strategy in which we take a deep dive into the vignette to harness our knowledge of physiology and try to make a prediction about the best answer choice. So let's jump in. We have a 45-year-old woman presenting with a 3-month history of fatigue, anorexia, unintentional weight loss, and episodes of dizziness. Her past medical history is significant for resection of non-functioning pituitary macroadenoma 1 year ago. On exam, her blood pressure is 90 over 60 millimeters of mercury supine, 80 over 50 millimeters of mercury standing. Physical exam reveals no skin hyperpigmentation. Laboratory studies reveal serum sodium of 135 millimolars per liter, potassium 4.2 millimolars per liter, morning cortisol 2.1 micrograms per deciliter, and ACTH of 5 picograms per milliliter. Which of the following best explains the patient's potassium levels? So before we even jump into those answer options, this question is a great example of how careful reading and interpretation of the patient's presentation and lab findings can lead us to the correct answer with confidence. Process elimination is a useful tool on multiple choice tests, but it can often lead to self-doubt, second guessing, and switching to an incorrect answer choice without trying to understand, or rather than listening to our first instinct, especially if we dive into the answer choices without trying to understand the patient's presentation first. So I'm going to encourage you to try to avoid looking at the answer choices until we've taken a deeper dive into the vignette. If we can make a preliminary diagnosis based on the information given and reason through the question using our knowledge of physiology, we can try to make a prediction of what the correct answer should be, or at least have thought through what the patient's diagnosis is and what the underlying pathophysiology contributing to their symptoms are. The goal is for the answer that matches our prediction to jump out at us, and we can choose it with confidence and then move on. By investing time in close reading of the vignette and application of our knowledge of physiology, we can save time and increase accuracy in the long run. We still may need to use process elimination during this process, but it will be faster if we go into the answer choices having reflected on the information provided. So let's jump into doing this. We are being asked for an explanation of the patient's potassium levels. Using our reference lab values, we can see that her potassium levels are normal. So let's reword the question. Why are the patient's potassium levels normal? As with many USMLE questions, there are multiple layers here. The first step is to identify the underlying pathology. The beauty of physiologic signaling pathways is that we have the tools to tackle anything a question throws our way. If we understand what is normal, we can reason through the patient's symptoms and lab values to identify what part of the pathway is broken. The patient's symptoms and laboratory findings are consistent with a secondary adrenal insufficiency. That is, the root cause of her problems are due to anterior pituitary injury rather than the adrenal glands themselves, which would be primary. This is key to identify. Thinking about our hormone signaling pathways, this will help us answer the question. So how do we know that this is a secondary adrenal insufficiency? So the symptoms of primary and secondary adrenal insufficiency are very similar. There's fatigue, anorexia, low blood pressure. However, primary adrenal insufficiency presents with skin and mucosal hyperpigmentation. This is because the pituitary gland is still functional and is churning out ACTH to try to stimulate the unresponsive adrenal glands. ACTH contains melanocyte-stimulating hormone, which stimulates the melanocortin 1 receptor and leads to increased pigmentation. Since this patient has no hyperpigmentation, this tells us her ACTH is not elevated, so this is unlikely to be a primary adrenal insufficiency. We are also given that she has a history of a pituitary macroadenoma resection, which should make us suspicious of possible iatrogenic injury to the anterior pituitary. Now let's interpret her lab values. Her sodium and potassium are normal, and her ACTH and cortisol are low. This is where we should pause and think about what could be broken in the hypothalamic pituitary adrenal axis to lead to these findings. We know ACTH stimulates cortisol release from the zona fasciculata of the adrenal cortex, so the fact that those values parallel each other makes sense here. Now let's tap into our content knowledge. What else does the anterior pituitary secrete that acts on the adrenal cortex? Let's think about the flat peg mnemonic. ACTH is the only anterior pituitary hormone acting on the adrenal cortex. We next need to consider whether cortisol affects potassium levels. Even if we are not sure, the fact that potassium levels are normal while the patient's cortisol levels are low suggests that the two are not directly related. This is something I might jot down while I'm thinking about the question. For example, cortisol is not related to potassium homeostasis. As just another tip or a side note, I'm a big proponent of taking notes while working through practice questions. It builds a habit of nailing down your thought process and helps make reviewing questions and seeing where your reasoning went wrong and learning from your mistakes a much more rewarding experience. Okay, going back to our question, now we can move to the adrenal gland. So what else is the adrenal gland secreting? We have androgens from the zona reticularis, mineralocorticoids from the zona glomerulosa. We know aldosterone, our main mineralocorticoid, controls sodium potassium levels, both of which are normal in this patient. So this tells us aldosterone should be normal as well. As another content knowledge tidbit, patients with secondary adrenal insufficiency can have hyponatremia. The low cortisol is in secondary adrenal insufficiency increases hypothalamic release of CRH and leads to ADH secretion and increased water reabsorption, causing a dilutional hyponatremia. Aldosterone is not affected. So if the sodium had been, for example, 130 millimolars per liter, don't be fooled. This is not a result of changes in aldosterone secretion, but rather in overall blood volume, which has increased. We now have a preliminary explanation going back to our question. The patient has a secondary adrenal insufficiency in setting of iatrogenic injury to the anterior pituitary gland. However, aldosterone has not been affected since it is not under the control of the anterior pituitary gland. So her potassium and sodium, although we weren't asked about that, levels are normal. Now we can go to the answer choices since we have a preliminary idea. We're saying aldosterone is not affected, hence her potassium is normal since aldosterone has not changed as a result of pituitary injury. So starting with answer choice A, low aldosterone in the setting of ACTH deficiency. We already identified that her aldosterone should be normal and that ACTH does not affect aldosterone levels. So we are going to strike that one out. Next, B, cortisol deficiency leading to renal potassium wasting. Even if we were not sure about cortisol's impact on potassium, the patient is not wasting potassium. Her levels are within normal limits. As another tip on any multiple choice test, if an answer is not 100% correct, it is 100% wrong. Many times parts of an answer choice may be true, but the overall answer choice does not answer the question or has another component to it that's not true. Be vigilant and don't be swayed by a partially correct answer. So we're going to cross out B as well. Next, C, iatrogenic injury to the anterior pituitary gland leading to increased aldosterone secretion. Again, even if we're not sure about the link between the pituitary gland and aldosterone secretion, in our thinking through the physiology, we know aldosterone decreases potassium levels. The patient's potassium levels are normal, so aldosterone is also likely normal. So again, we are going to strike this one out. For D, release of aldosterone independent of serum ACTH levels. This is the answer we're looking for. It matches our prediction from our thought process. If I were taking the actual exam, I would pick this answer and I would move on to the next question. During practice and here today, for the sake of the exercise, I still recommend evaluating every single answer choice to make sure you can identify why any remaining choices you haven't evaluated are not correct. It's a really good exercise to test your understanding of the material. So we like D, but let's evaluate E as well. So hyponatremia stimulating aldosterone release and renal potassium excretion. Using our reference lab values, we will see that sodium is normal. This is a great example of a true statement that is not answering the question. Hyponatremia can stimulate aldosterone release, and the aldosterone would lead to loss of potassium out of the kidneys. However, our patient has a normal potassium level, so this doesn't explain her laboratory findings. So once again, we can cross that one out, and we have definitively narrowed in on D as our correct answer. So we did it. I realize this process of digesting the vignette information takes time, but building the habit of investing that time now will make this process faster in the long run and allow you to increase your accuracy and time in answering questions or decrease your time in answering questions. So keep doing quality practice over quantity.